Background. Since aging and chronic kidney disease are both risk factors for various forms of sleep-related disorders, including poor sleep quality, obstructive sleep apnea, OSA, central sleep apnea, SISA, restless syndromes, and periodic limb movement disorder, their prevalence becomes higher with the increasing number of elderly patients with type 2 diabetes mellitus. We recently reported that poor sleep quality based on short-term sleep latency determined with electroencephalography is independently associated with impaired lipid and glucose metabolism in type 2 diabetes mellitus, leading to outer wall stiffening in those patients. However, it was reported that high prevalence of sleep-related breathing disorders, SRBDs, including OSA and SISA in hemodialysis patients, has been established as a significant cardiovascular disease CVD risk. Since volume overload and inadequate dialysis cause either OSA or SISA, coexistence of SRBDs may contribute to the development of CVD events in hemodialysis patients. Therefore, to examine the association of poor sleep quality with CVD risk, the association should be investigated after the exclusion of the effect of OSA, SISA, and sleep disorders induced impaired metabolism. In the present study, we evaluated correlation of sleep quality markers, including polysomnography, determined REM sleep latency was with various metabolic markers at baseline in hemodialysis patients. The association of baseline level of REM sleep latency with the development of CVD events in a longitudinal design in HD patients after excluding the influence of OSA, SISA, and metabolic markers at baseline. Method. Present study investigated baseline levels of objective sleep architecture together with OSA and SISA using polysomnography in 80 HD study participants. Male was 56, female was 32, and the age was 68.4 years. Then HD study participants were monitored for occurrence of new onset CVD events with a medium range follow-up period of 33 months. Definition of CVD. One, presence of significant stenosis by coronary angiography. Two, presence of STT abnormalities on electrocardiogram associated with type 2 typical syndromes attributable to angina pectoris. Three, presence of cerebral vascular disease by CT or MRI with typical symptoms attributable to stroke. Measurement and analysis of PSG data. Overnight PSG was performed as a measure of sleep architecture, total sleep time, REM sleep latency, sleep efficiency, and sleep stage were classified by EEG into 4 stages: wake, stage 1, stage 2, and the slow wave sleep stage, and REM sleep stage. REM sleep latency, which is defined as an interval between sleep onset and the first REM period, might provide a clinically relevant objective measure for sleep quality. REM sleep latency means the first sleep cycle, the most important, deepest sleep cycle. Delta power, the marker of the deep sleep, is highest in this interval during sleep time. Baseline profiles and the sleep architecture of the 80 hemodialysis patients. The relative duration was 21.8 years, 40.9% was type 2 diabetes, 38.6% had a pre-existing CVD history. Non-HDL cholesterol was 109.3 milligram per deciliter. KT/V was 1.6. On sleep architecture, total sleep time 349 minutes. REM sleep latency was 150.5 minutes. Sleep efficiency was 56.9. Slow wave sleep was almost deficient. On sleep apnea, HI was 33.0, central HI was 0.7. Mean oxygen saturation was 9050.8. Univariate correlation of various clinical variables with REM sleep latency. Only REM sleep latency has significant negative correlation with TG and non-HDL cholesterol in all patients. And in diabetes mellitus, REM sleep latency had a significant negative correlation with FPG and hemodialysis. This is a graph in all patients. REM sleep latency has a significant negative correlation with TG and non-HD cholesterol. In diabetes mellitus, adding TG and non-HDL cholesterol, REM sleep latency has a negative correlation with significant negative correlation with FPG and HemA1C. Brief summary: among various measurements of sleep quality, REM sleep latency, interval between sleep onset and the first REM period alone correlated in a negative manner with triglyceride and non-HDL cholesterol in all study patients, and with fasting plasma glucose and A1C in study participants with type 2 diabetes mellitus. Next, we do a evaluate Cox proportional hazard analysis on sleep architecture with about the CVD instance. REM sleep latency only has was a significant cause of CVD instance, not HI and CHI oxygen saturation has no significant cause of CVD instance. We did a Kaplan-Meier event free survival curves. We divided into two groups. Medium REM sleep latency using medium REM sleep latency. Red colors one is lower sleep medium sleep latency has a lower free sleep event-free survival rate than those of higher REM sleep latency. Next, we did a stepwise logistic regression analysis. REM sleep latency and age, gender, dialysis duration was significant risk factor for new onset of CVD events. We did 13 items were included as independent variables comprising basic factors: gender, age, dialysis duration, CVD-related factors, diabetes mellitus, historic blood pressure, non-HDL cholesterol, statin use, cardiovascular disease history. Sleep-related factors, REM sleep latency, HI, central HI, medium oxygen saturation, sleep-promoting drug use. Still has REM sleep latency is detained significant as independent risk factors for new onset of CVD. Next, we did multiple Cox proportional hazard regression models for CVD event onset. In model 2, adding non-HDL cholesterol. In model 3, central apnea hypoxia HI central HI in model 4, oxygen saturation. In model 5, cardiovascular disease history. In model 6, diabetes mellitus. Number 7, systolic blood pressure. But still, REM sleep latency remains a significant and independent risk factor for new onset of CVD events. Brief summary: in the Kaplan-Meier analysis, hemodialysis study participants with shorter REM sleep latency had a significantly higher rates of new onset CVD events than those with longer REM sleep latency. Stepwise logistic regression analysis and multivariate Cox proportional hazard regression analysis identified shorter REM sleep latency as an independent risk factor for the development of new onset CVD events, independent of mean oxygen saturation, HI, central HI, diabetes mellitus, CVD history, systolic blood pressure, statin use, and non-HDL cholesterol. Conclusion: the present study demonstrates that reduction of REM sleep latency is independently associated with the higher rates of new onset of CVD events, independent of SRBDs, OSA, and CISA, and diabetes mellitus, non-HDL cholesterol in HD study participants, citing impaired sleep quality as a potential CVD risk factor, and thus a definite treatment to target to protect against CVD, especially in HD study participants. REM sleep latency might be a new risk factor of CVD events in hemodialysis patients with SRBDs. Thank you for your attention.